And today you're going to take us through a general introduction to the map of medicine.
First and foremost, the map is a refresher course for all clinicians across all areas. So for example, junior doctors in training might want to be able to quickly look into a specific area and update themselves, or a general practitioner in the same way. Even a specialist working outside of their specialist area, of course, in their own specialist area they wouldn't need the map of medicine, but outside their area they might want to just check up something for a patient that has another disease which is outside their area. That is where I would see it being quite useful. So first and foremost, this is a quick refresher reference, but then going forward, once it's integrated into the underlying infrastructure, if you like, of the healthcare system, particularly the IT infrastructure, such as electronic medical records, you can then start to use the map for triggering clinical actions from within the context of the map. So you're not scrambling around looking for referral forms or which test tube you need to put this sample into and so on. So it actually allows you to trigger clinical actions directly off the context of the map, from the map interface. And that's when it starts to be directly integrated into the clinical workflow.
Your job is to make sure that it has a practical clinical focus. How confident are you that it does achieve that?
The entire map interface has been built with clinicians, NHS clinicians, from the get-go, dating back to 2000. Indeed, the very first prototypes were developed directly by 26 general practitioners, about 50 hospital consultants, and about 10 specialist nurses. They were based at the Royal Free Hospital with the surrounding community, and they in fact helped us develop how they wanted their knowledge displayed and then what knowledge they wanted displayed using that interface. And that's where the separation of the clinical thought flow, the flow charts, came from the text-based information which slides out from the side. And it's that simple separation of clinical thought flow from the detailed knowledge which allows you to get to the information much more quickly than if you're using a roll and scroll textbook.
So can it be personalised for individual groups of health professionals?
Absolutely. The entire map is localisable to 3 different levels. At a personal level, each clinician will have their own login, and they can then put post-it notes on the map very easily. So they can annotate the map with little prompts and reminders of their learning, or if they're having a multidisciplinary team meeting or some sort of educational training meeting, they can print off the map with their post-it notes. And part of the technology means that the post-it note appears in the relevant against the relevant node on that printout. And that's quite useful. And in fact, one of the most powerful uses of the map today is for people involved in planning for healthcare services, commissioners and managers, if you like, clinical managers, who have then a visualization of the healthcare journey, the idealized evidence-based healthcare journey for a patient through the healthcare system for specific diseases. What the map doesn't do, and this is very important for everyone to appreciate, is that it's not an expert system. It's a map. It's a guidance system. And it's a clinician-driven interface. So the clinician is free to choose how to jump around the map. There are no hoops and loops you've got to jump through in order to get to another stage. It's not an expert system. It's not doing black box calculations in the background.
Who's checking the veracity of the information that's contained in the map?
We're not creating new guidance. We're taking the existing guidance, such as from NICE, such as from Cochrane and so on, and taking that information and distilling it and displaying it in a way that's intelligible and quick to access for clinicians. And where there are conflicts, because there are sometimes conflicts between NICE guidance and, for example, Royal College guidance, because of the timing of the publications. Some are 1 year old, some are 2 years old, some are very new. And where there is that conflict, we can represent that conflict on the interface, because it's a dynamic interface. That's what we call XML based. So it means you can surface, using the web, the internet, those conflicts, and then allow people to make comments, and if you like, the map mediates a dialogue between clinicians, particularly across the care settings, between primary care and secondary care as an example. The principle here is that this is a professional tool for clinicians, and that as clinicians we need to have a benchmark, if you like, or some sort of visualization of the evidence-based best practice journey against which we can say, well, I'm now going to go off-piste. But it's important to know when you're going off-piste. So a junior doctor or a locum staff in a local setting can get access to the best information, but then still having a conversation with a consultant or with whoever can actually make a rational decision saying the patient doesn't fit this specific journey, because we know that human beings are complex. I mean, the unit of transaction in healthcare is a human being, not just the individual, but their whole social context.
Dr Mike Stein, thank you very much for your time.